Good morning to you all and welcome to the 7th lecture of the 2019 Palliative Care Lecture Series. Hospice New Zealand would like to thank and acknowledge Cancer Research Trust New Zealand for their generous support and funding to deliver these free lectures. The lecture today will be recorded and it will be available on the Hospice New Zealand website. Please be aware there will be an opportunity for questions at the end of the presentation. We would now like to introduce our guest speaker today, Associate Professor Geoff Sussman. Dr. Sussman holds a position in the Faculty of Medicine, Nursing, and Health Sciences at the Monash University and is Associate Professor of the Wound Care in the Monash Institute for the Health and Clinical Education. He is a wound consultant at the Wound Clinic, Austin Hospital. Please go ahead, Dr. Sussman.
Thank you and good morning. And it's a pleasure to be presenting to you, having personally been involved with palliative care with my late wife. I know just how important palliative care is and the wonderful work that you do. So hopefully you've got my introductory slide on the screen and we'll move to the next slide. Pressure injury is the most preventable of all chronic wounds. Pressure injury may be as simple as just a blister that you get from a new pair of shoes. It can be extensive pressure injury that someone who's bedridden, people particularly with diseases like stroke or spinal injury or multiple sclerosis or dementia, and particularly in relation to receiving palliative care. It all depends on the impact of pressure directly on the arterial blood system. The mean capillary pressure in artery is about 30 millimetres of mercury, and anything that's in excess of 30 millimetres of mercury is in fact going to stop the flow of blood through the arteries. And what this does is it then cuts off the supply of oxygen, of nutrients, of all of the important cells to the tissue, and it means that all of the waste products that should be normally removed are being left at the site of the tissue, and certainly if there's an injury. What happens there is hypoxia. If you have no oxygen, you then affect the tissue, you get increased capillary permeability, which causes this intravascular escape of fluid, edema, and ultimately causing cell death and ischemia. Direct pressure over as I said, is 30 millimetres of mercury will cause ischemia. And this will only be from the patient being in bed. You can get this from any time that you're sitting or standing or lying in a position, on a trolley, in a chair, and the amount of injury that you will get will depend very much on the intensity of the pressure and the length of time of the pressure. This remains unrelieved. And it's surprising that the tissue can tolerate a reasonable amount of pressure for short periods, but even low pressure can, over a long period of time, will have a detrimental effect. A good example of that is what we get on our heel. Friction. Friction occurs when the top layer of skin are worn away by continued rubbing against an external surface. This can be a simple blister. I'm sure many of you have experienced this with a new pair of shoes. And again, this can ultimately relate in either a blister or an open wound itself. And this is not uncommon. Even bed linen can cause the problem. Shear. Shear is when the skin remains in place and unable to move, but the bones move. And you find this both in a bed and in a chair when the skin will stick to the surface, but there's slipping down, and what happens is the bones move backwards and forwards, and this causes the shearing injury. And certainly bed linen, surface of a chair, places this will happen. The most common wounds found in palliative care include pressure injuries, arterial and ischemic wounds, certainly cancer wounds and surgical breakdown. The prevention and management of pressure injury requires that the patient has pressure-relieving surfaces on which to lay. And I'll talk more about this as we move along this morning. And the wound itself needs to be managed, and it will very much depend on the type of wound, the size of wound, the depth of wound, the type of tissue involved, and if there's infection, which of course has got to be treated as well. Pain is a very important consideration, and I know that in palliative care, pain is a very constant problem, and wounds can become painful. There's no doubt about that. And The problem is that the periskin itself, the skin around the wound, becomes very sensitive and very painful itself. And for some people, even the lightest touch can be intensively painful. And this is something that you need to be aware of, and particularly in a patient who can't directly communicate with you. And we'll talk more about the way you can recognise this in a moment. All patients with pressure injury should be regularly and routinely assessed for the presence of pain. And pain management should be holistic. It's not just in relation to pressure injuries, but every particular patient should be individualised for the way that you manage their pain, and you should have a plan to manage their pain. Select a validated pain assessment tool, and there are many of these available. There's Northner's, Waterloo, there's Gillies. It's a whole range of them, but it's important that you do have one that you use and use the same one. So don't swap from one to the other because they do vary a little bit. But pain assessment should include observation of body language, and particularly in patients who can't communicate. This is very, very important. And all pain assessment should include the tool used and the assessment findings on the document. I'm a great believer that everything that you see and do should be documented. Refer patients with chronic wound pain if necessary for some specialist help as well. You need to individualise, not just any medication, but also non-pharmacological interventions. And think about the patient themselves, because often they will have preferences in relation to the way you manage their pain. Topical treatment of pain in wounds is not normally recommended, but in palliative care, in my opinion, that goes out the window because your role there is to keep the patient as comfortable as possible. Now, some of these are not even commercial. They have to be made. And topical opioids are one thing that is used. And I'll talk more about that in a moment. You have to address all the factors, the positioning, the support services they are lying on, continence issues, because remember, incontinence, whether fecal or urinary, can have a significant effect on the skin itself, and you can develop continence-induced dermatitis, and that can be quite uncomfortable, and increased muscle tone as well. If a patient is experiencing moderate to severe pain, then the wound management should be very much reviewed because something has gone wrong. If necessary, talk to a pharmacist for advice about how best to prepare any topical preparation, like such as topical morphine, that you might be thinking of using. Analgesic medication are used to provide symptomatic pain relief, and don't modify the underlying cause of the pain. Always remember that. All that an analgesic will do is dull the understanding of pain in the pain centre of the brain. You need to combine pharmacological and non-pharmacological approaches if you're going to get the best result, and allow you to use lower doses. And the problem here is if you're using very high doses of particularly opioids, this will have such an important effect and side effect on the body and on the cognition of that patient. So that's very critical as well. The World Health Organization has an analgesic ladder, and it goes from simple analgesia for minor pain, adding non-steroidals or codeine for more severe pain, and then ultimately opioids for the very significant pain. And your choice of an analgesic will depend on the pain type. There's basically two sorts of types. The normal nociceptive pain is where the nerves are functioning normally, and we use normal analgesia for that type of pain. Neuropathic pain, on the other hand, is where the nerves are damaged, and we manage them in a different way. And interestingly, we use things like tricyclic antidepressants. We use drugs like gabapentin and pregabalin that were drugs that are actually used for epilepsy, and also we'll use topical things like glycerol trinitrate patches or glycerol trinite ointment as well. Non-pharmacological methods include the use of things like relaxation. It's amazing how you can calm someone down with a bit of relaxation, a bit of gentle massage, try to work out coping strategies, distraction. Because remember that pain is as much in your mind as it is physical. In the case of feet, warm socks, having the legs dangling down. And one way of doing that is to raise the head of the bed so that arterial blood flow will go down. But again, with any therapy, particularly with analgesic therapy, you have to have a goal to make them either completely relieved of pain, but that's rarely deliverable, especially in neuropathic pain. So you want to make them as comfortable as possible. And it has to be a balance between relief of pain and maintenance of function, because what you don't want them to be is so out of it with the level of analgesia you're giving them that they can't communicate. And it's important they can communicate, particularly with their loved ones, their family, and with staff as well. Where pain is the issue, it must be established that the pain is constant, intermittent, or is it just at the time you're doing a dressing change? If that's the case, then you need to think out of what products you're using, and it may be, frankly, the product you're using that's actually causing the pain. We tend to use soft silicone dressings because they are the least likely to cause pain when you have them on, but also because they're atraumatic on removal, that minimises the risk of pain when you actually use the dressings themselves. So we generally tend to use, in these types of patients, the silicone product, and there are many of them on the market. Again, topical analgesia. You can use patches. There are a number of patches on the market. You can use gels. You can use products like capsaicin, and local anaesthetics like lidocaine or similar. Again, we've certainly used topical morphine in palliative care, and the way we use the topical morphine, we take a standard ampule of morphine, let's say a 10 milligram ampule, and we use it in a proportion of 1 milligram of morphine to 1 gram of a sterile hydrogel, such as a intrasite gel, and you mix them immediately and you apply them, and usually apply them every 8 hours. You can also use topical lidocaine from 3 to 5%. In addition to analgesia for pain, again, I talked about the use of pain assessment, and you need to do the pain assessment on a regular basis to make sure that you're having the appropriate effect of your analgesia. Again, I usually say if you're going to be doing dressing changes, make sure you give the analgesia before the procedure, at least say 15, 20 minutes, so that there is at least a level of analgesia before you start changing a dressing. It's also very important that you do use dressings that are atraumatic. Very important. And I think it's always helpful to develop guidelines to prevent tissue damage and to educate staff about pain and about trauma with dressing. Odour. Odour is certainly a significant issue, and it's one of the most distressing symptoms of chronic wounds. It's complex. It's multi-component, and it could be something as like an infection or tissue necrosis. And it can cause terrible depression, social isolation, nausea, anorexia, and in some individuals, gagging or vomiting reflex, because it's very unpleasant. The presence of particularly anaerobic bacteria, but sometimes aerobic, can cause odour, but it doesn't always indicate infection. What happens is that you've got a level of bacteria colonised on the surface of the wound, which causes the odour. And this is not, in fact, infection itself. Odour removal is very important. It impacts not only on the patient themselves, but the family and, of course, the staff as well. The management of odour will depend on the cause. The most commonly used treatment, and it works very quickly, is topical metronidazole gel. Now, please don't take Flagyl tablets or similar and crush them. That's inappropriate. There are commercial metronidazole gels on the market, and they will kill the anaerobic bacteria very, very quickly. Within a matter of a day or so, the smell will be gone. You can use silver, you can use iodine dressings, and even honey, which is very popular in New Zealand, which will also help to reduce the odour. The other way that you remove odour is you can use absorbent dressings that contain charcoal. Now, there are a number of these on the market. Some also combine charcoal with silver. And there are some, particularly in the very complicated cancers, fungating cancers, that will have a hemostat and absorbent fibres and also the charcoal in the one product. So let's look at the issues for palliative care pressure relief. Firstly, you need to have a comprehensive assessment of every patient to identify pressure injury risks, because the risk is important to identify. Secondly, inspect the skin of all patients when you first see them on admission and at each repositioning to identify if there are indications of pressure injury. The earlier you identify, the quicker you can intervene. Thirdly, implement preventative strategy. The best way to not have to deal with the pressure injury is to prevent them. Again, good skin care. Next, provide high-protein oral nutritional support. And there's very good evidence that good levels of protein help to minimise the development of pressure injury, but also help speed up the healing of them if that's the intention. The next point is to use higher specification, reactive, constant low pressure support foam mattresses on the bed and on trolleys for patients at risk of pressure injuries. There's no one specified high reactive or constant low pressure support foam mattress that's better than the others. The next option is active, alternating pressure. These are mattresses that can be used as an alternate in patients with high risk of pressure injuries. Next, only consider using a medical-grade sheepskin as an adjuvant or when high specification reactive, constant low pressure or active alternating pressure support surface are unavailable or not tolerated, because a sheepskin will help friction and shear, but does very little for pressure itself. Any device that you use to prevent pressure heel injury should be selected and fitted appropriately, because a good heel device should in fact have the heel sitting with nothing on it at all. The heel itself should be just in the air, but supported around it. Next, use a support cushion for patients at risk of pressure injuries, whether sitting on a chair or in a wheelchair. That's important. The next point is repositioning patients to reduce duration and magnitude of pressure over particularly vulnerable areas. And these are bony prominences, particularly, and also the heel. The frequency of positioning should be considered depending on the patient itself. And again, the risks of development, skin response, comfort, function levels, medical conditions, comorbidities are important, and the support service you're using. A known major factor for the development of and healing of pressure injuries, as I said, is nutrition. Patients who are poorly nourished are more likely to develop pressure injuries. And this, of course, is one of the significant problems within palliative care, because often you have difficulty in a patient having a quality diet, and the use of supplements is therefore very important. Again, we all need a balanced diet, but certainly protein is something that's been clearly shown that makes a difference. Again, to reduce the risk of pressure injury, patients who have been identified as being malnourished or at nutritional risk, you need to help and work with. Again, conduct nutritional screenings. And there are good, simple, validated screening tools that you can quite simply identify if a patient has a problem. Again, consider referring a patient to a dietitian if you really want some additional help. But as I said, high protein nutrition is as much important as anything we can do to prevent the risk of pressure injury. Assessing. Again, conduct a head-to-toe skin assessment, particularly focus on underlying bony prominences. This is the sacrum, the heels, the ischial tuberosities, the greater trochanters. All of these areas are going to be the greatest risk. That's the hips, the heel, the back of the spine itself. Look for skin damage. For instance, skin damage from devices, a brace, a splint, a harness, cervical collars, hip protectors. Even you can get it from oxygen cannulas around the face. So be aware that these can induce pressure injury as well. Again, if you can, the devices should be removed to allow a comprehensive skin assessment at least daily or even more frequently in higher risk patients. Again, as I said before, document. Very important from the time you first see them within a minimum of 8 hours and on a daily basis, or when the patient's condition changes. The two primary sorts of support services are reactive. Again, that's constant low pressure. These are support surfaces, and also active. These are alternating pressure surfaces. A reactive or constant low pressure support surfaces can be either powered or non-powered. In other words, has the ability to change as its load distributes properties response to pressure load. A reactive or constant low pressure support molds to the patient's shape. That's immersion or envelopment in order to redistribute the body weight over a much larger surface area. The interface pressure remains constant while the patient remains in one position, but is redistributed over a wider surface. Protecting the patient's heel in bed is very, very important, because remember, just putting on a mattress or a device protects the back and the legs, but it doesn't protect the heels. Let's have a look in more detail, next slide, of the two different systems. The pressure-reducing ones decrease peak interface pressure. In other words, these are cut or layered foam, static air or gel fibers, or low loss air ones, or fluidized, like a waterbed is a pressure-reducing device. Pressure relieving removes the interface pressure, and these alternate. These move up and down so that the pressure is not constantly on the one spot. Again, the active alternating pressure support surfaces produce an alternating pressure through the mechanical by this is up and down movement. It's like a wave flow across the body as the cells activate, deactivate, activate and deactivate. And research in the field suggests that high specification foam mattresses are the most effective reducing pressure injury for reduction. Well, with the evolution of more affordable high specific foam mattresses, the use of mattress overlays like egg crate foam is not recommended in most settings. Again, the research on high specification mattresses report a wide variety of products, and you need to look at them because there's not a lot of information sometimes about the specificity. Let's look specifically at the different types of these alternating devices. And often people think once you've got them on them, that's the end of the issue. One size fits all. Well, in fact, that's not the case. A larger patient has too much weight to be adequately supported by the preset mattress. In particular, the sacral area is not supported by the internal cushion pressure and bottoms out. And therefore, there's still a particular risk because of the underlying frame of the bed of developing the pressure injury, particularly in the sacral area. Again, smaller patients have the opposite effect. The patient experiencing high interface pressure, particularly in the bony prominences of the heel and the sacral area itself. Articulated bed positioning can bring additional complexity to the matter. Changing the position redistributes the body weight and increases the pressure in the seat section. So, as you can see from the slide, by changing the position of the bed doesn't remove the risk. In fact, in some cases, it actually increases the risk. The mattresses don't sense that something has changed. So, once more, the caregiver relies on his or her visual assessment and intuition to adjust the mattress in order to accommodate this new position. Again, too strong support comes from the mattress overinflation, and it's very critical that the level of inflation is correct. The flotation line of the patient is above the surface level. So therefore, this results in a build-up of multiple pressure points and discomfort and increased risk for the patient. So again, there's another example, and you can see there are multiple spots where pressure can happen from the head, from the shoulder, from the sacrum, from the hip, from the calf and the heel, because the device is overinflated. Again, too little support comes from insufficient mattress inflation. Again, that's the opposite. The flotation line of the patient is too deep inside the mattress contour, and this is a bottoming out effect, and again can lead to multiple pressure points, particularly the shoulder, the sacrum, and the heel itself. Limited or no mattress adjustability of a standard air surfaces can lead to higher incidence of skin breakdown. A solution is to remove the one-size-fits-all approach by introducing advanced technologies to allow support surfaces to automatically adjust and accommodate the different patient and position. The surface ideally should support the patient regardless of the variations in morphology of the bed frame articulation. Again, this can be achieved through immersion, where the patient is in equilibrium between the individual patient and the level of support provided. And you can see in the slide that that's what you want. The flotation line is aligned to the mattress surface. This results in minimized interface pressure and increases patient comfort and, of course, safety as well. Seating support cushions. There's a large variety of seating cushions available, from low-end foam-type slabs to air-filled cushions. There is currently minimal research on the effectiveness of support cushions. Most trials are focused on comparison or of different types. However, most of these trials are small and of low quality and provide insufficient evidence to recommend any specific type of surface. Avoid excess linen between the support surface and the patient's skin. This is where the shearing injury will happen. Consider and monitor the skin's microclimate when selecting support surfaces, and especially applicable to enclosed heel protection devices, as I mentioned before. Avoid the use of synthetic sheepskins. If you're going to use sheepskin, it's got to be a real sheepskin, not synthetic. And cutouts or rings or donut devices or fluid-filled gloves or bags is inappropriate to use. When seated, high compressive forces are primarily generated through the ischial and sacral region. If there's poor postural support and the patient develops a slump position, again, these shearing forces come into play and will cause a problem. And this is distortion, kicking of blood vessels, endothelial damage, tissue deformities, and is a great probability of tissue damage. Consider the patient's position sitting in a chair. All the weight is now being transmitted through a much smaller surface area. Research has shown that when seated, 75% of the weight is taken up through the thighs and itself, 90% in the buttocks, and about 4% through the feet and 2% in the arms. And you can see from the picture that, firstly, you've got 75% in the sacrum and 90% going through to the heels, and the sliding down in the chair gives you the friction and also shear. Sitting should be reviewed as a special therapeutic piece of equipment, not just as a piece of furniture. Very, very important. Both chairs and cushions are important, and a range of equipment should be available to suit different weight dimensions and risks and the need of the patient. The aim of appropriate seating is in the position is to make the patient's weight as much as possible taken via the largest bearing surface of the body, the thighs and the buttocks. Posture is important, and aspects of the provision of chairs of appropriate height and dimension is required in order to get the best performance from any cushion itself. So it's not just the cushion itself, but it's the device you're putting it on that's important. Alternating seat cushions are primarily designed for those of the highest risk of pressure development, and certainly ones that already have pressure damage. Pressure-reducing cushions are those which redistribute the seated person's weight, maximising the surface area upon which the legs and buttocks rest as the most risk surfaces. Let's now move to skin protection. Employ appropriate manual handling techniques in line with occupational health and safety guides when repositioning. I've seen patients who are pulled across the bed on a sheet, and of course that is totally inappropriate because you're actually creating shear by doing so. Again, provide transfer assistance devices. Again, overhead devices. And again, try and promote independent patient transfer and reduce shearing forces and friction. Don't rub vigorously. There's a very old tradition that you get 50% paraffin oil and 50% methylated spirits and give the bottom a rub to prevent pressure. And that's completely wrong. It has the opposite effect. Evidence has clearly shown that massage actually makes things worse, not better. Develop and implement individualised continence management plan, as I mentioned earlier. Very important. And if you're going to use a skin cleanser, use ones that are acidic pH. Soap is totally inappropriate because all soaps, or the vast majority, are alkaline. And this will have very significant impacts on the skin itself. Use quality skin emollients, which I'm going to talk about in some detail in a moment. And depending on the person's skin, either a cream or an ointment or in very fragile skin, a lotion. Neoplasia, cancer, both directly and indirectly plays a major role in palliative care. I'm sure you have seen this. Many patients with terminal cancer of varying types are referred to palliative care. Again, some specific cancers are fungating breast cancers, and they're an enormous challenge to manage. As I said, there is a product that will combine both something to stop bleeding, something to absorb exudate, and something for the smell in the one product. And these are available on the market. They're painful, they are exudating, they're smelly, and again, they bleed. And they can hypergranulate. These squamous cell carcinomas can develop in a non-healing wound. And this is one of the problems. They're called a Marjolines ulcer. And again, some of these will metastasize quite nastily. There are many forms of treatment for skin cancer, but surgery is the most effective. In palliative care, this may not be something that you would even consider. But again, you have to then manage them. These are complex wounds, and again, odour, bacteria are always secondary issues with these particular types of wounds. Skin integrity reduces with age. Unfortunately, as we get older, we lose dermal thickness, the skin becomes very fragile, we no longer produce vitamin D, the collagen and moisture is reduced, the migration of capillary and tuberous cells goes down, the epidermal turnover is reduced, the blood supply becomes fragile and is reduced, and there's a compromise of the inflammatory response. And of course, if you've got comorbidities and you're on many medications, these impact also on skin integrity and on the ability to heal. It's important to ensure that all patients receive good skin care, and the skin integrity is assessed regularly and is in greater emphasis on skin protection in these patients. Good skin care can have a significant impact to reduce skin damage. And again, adequately hydrating the skin with effective moisturising agents, whether creams, ointments, lotions, and really ointments and lotions are better than creams. And they should always be applied twice daily on dry skin areas and on extremities. The essential aspect of the use of moisturisers is to use ones that won't, in fact, cause damage. And it's very clear that some of them do. For years, we've used things like aqueous cream. And what we've found from evidence is they increase transepidermal water loss, in fact, dry the skin. And in fact, some of these have been shown to be cytotoxic to cause damage to skin cells. Again, you can clearly see the difference between young skin and old skin. And dry skin will increase the risk of skin breakdown and the reduction in skin barrier function. And that skin barrier is very important because an intact skin is a barrier for nasties getting in. A damaged skin becomes a portal of entry, which is not good. Again, we have a simple scale from smooth skin with no evidence, 0, through a series of levels to level 4, which is extremely dry skin. Again, very scaly, pronounced separation of edges, and certainly cracking. Just to clarify some terms, an emollient is an agent that softens and smooths the skin. A moisturizer is an agent that adds moisture to the skin, and a skin barrier is an agent that protects the skin from chemical agents, mechanical trauma, and continence issues as well. Lipids. Part of our skin structure are natural fatty acids, and they're an important part of our dermal transport mechanism. Lipids are found in the stratum corneum and are part of the formation of the permeability barrier. because of their high melting point and polarity, which results in water resistance of the lipid bilayers. Again, what lipids, where do we get them from? Well, animal fats, vegetable oils, mineral oils, synthetic oils, and waxes. Again, there are various types of emollients that you can get. The normal aqueous and cream type are what we call an oil-in-water emulsion. They're basically water with a bit of oil. Oil in water. Water in oil, where there's mostly oil, these are the fatty type ones. And, of course, your standard ointments are paraffins or waxes or glycols. Again, what do emollients do? They prevent the movement of water out of the skin, relying on interposing an impervious barrier. Again, there's usually a lipid, fat, between the skin and the environment. What do emollients actually do? Well, they're anti-inflammatory. Again, we know that they actually will soothe inflamed skin through their ability to inhibit the production of pro-inflammatory prostanoids and blocking cyclooxygenase activity. They're antimycotic. Emollients contain mineral oils that have an antimycotic effect on the epidermis. Again, this is also important to understand. And antipruritic. They actually reduce itch. So they can be an important modality if the patient is having some itchy skin. Many topical products have complex formulas. And I tend to look at the formulation on many of these products, and they contain so many ingredients. You don't need those sort of products. You want simple products, not complex products. Again, they contain preservatives. And again, I think that's important. Products that are multiple use will need to, particularly creams, to have preservatives. There are some newer ones which don't have preservatives, and look for those. I think they are useful. Antioxidants are also in the formulation, and pH buffers. We want to try and keep things away from the alkaline type of preparations, which can make things much worse. Again, viscosity. Things that are thick tend to stay in place longer than things that tend to run away, and that's important. Again, surfactants. These are things used to clean. We tend to use ones that are pH acidic and that are very mild. Things like QB wash are very useful. Some people use antiseptics, and generally speaking, you don't need antiseptics. Again, emulsifying agents in compounds can be there as well, but don't use soap. As I said, soaps are quite detrimental on the skin. Again, these preparations contain a whole range of ingredients in their formula. Urea. There are some products that contain urea as something to maintain moisture. And yes, up to 10% might help to do that because they decrease transepidermal water loss. But beyond that strength, they have the opposite effect. So generally, we don't tend to use urea products. Soft paraffin is derived from petroleum, and it's an ingredient of many products. Again, yellow soft paraffin, white soft paraffin, which is just bleached. Cleansers and moisturizers are needed to help maintain good skin condition. And again, the skin provides this mechanical strength and resistance. It's very important that you remove any foreign substances or microbes when you clean the wound. Cleansers are designed to remove dirt and sweat and sebum and oils from the skin. And again, a quality cleaner is going to minimize secondary damage. And be gentle when you use them. And again, the pH, as I said, needs to be acidic. Skin is naturally acidic. So again, don't vary that. And it's very clear that most soaps that we use are highly alkaline. You can see from this slide, the common soaps that you use, even on yourselves. In fact, you shouldn't be using soap on yourself because they're all alkaline and they will completely alter the functionality of skin. High pH cleansers and soaps are completely out. So don't use them. The cosmetic soaps, again, don't use them because they're going to be alkaline. Again, be gentle, use quality cleansers, but be careful when you use them. A moisturizer is a product designed to help treat and prevent dry skin. It's common to think that moisturizer adds water to the skin. It doesn't. It's a misunderstanding. A moisturizer works by preventing the loss of moisture from your skin. There are other products that actually add moisture, but a moisturizer actually prevents. The terminology surrounding moisturizer can be very confusing. So we can define in a few words. Moisturizer and emollient are often used interchangeably. A moisturizer is the finished product. An emollient is an ingredient of a moisturiser. A moisturiser is needed to keep the skin looking young and fresh and healthy, hydrated, plump, luminescent, and elastic. Again, dehydrated skin is tired looking, particularly around the eyes, and dull and lacks spring and elasticity. And again, this is very important. And while I talk about moisturising and also talk about hydration, it's hydration of the body itself is important. Humectants are hygroscopic. These are the ones that actually add moisture. They're different, again, to your normal moisturiser. Emollients provide an oily film over the surface where they trap water. I've talked about these earlier, and they're very important. While it may look very straightforward to create a good moisturiser, there are good examples, as I mentioned, aqueous creams. And they were originally introduced as a soap substitute. And many of these contain things like sodium lauryl sulfate. And again, it's part of a wash-off one, and it shouldn't be left on there. And it certainly will damage to both normal and atopic skin. Again, when you use this, and there's very good evidence of them, it's going to have a negative effect on the skin. Again, when applied to atopic skin in particular, there's a bit of eczema dermatitis. Again, this significantly increases the barrier function, increases skin permeability, and leads to worsening of skin condition. And the evidence is quite clearly there. So what you want, next slide, is a moisturiser that puts this barrier on the skin, and it prevents the loss of moisture to the skin. Using appropriate moisturising agents to ensure suppleness and to maintain the drying, to minimise the drying effect. Creams, ointments, bath oils, barrier films. Again, sorbolene is another type of aqueous cream. And I've given you a couple examples in the next slide of some of the evidence that clearly shows the effect on transepidermal water loss and some of them on cell damage as well. Again, this is another one of the pieces of evidence that clearly showed that transepidermal water loss was significantly increased when using these aqueous type creams. Again, this is another one which reported rapidly minimising invasive measures of the effects of aqueous creams. So again, think carefully, and I would not be using these types of products at all. And this is a study done in Australia which looked at the cytotoxicity of a number of things. And you will notice that aqueous cream is high, paraffin ointment is high, and even things like the silver sulfidizing cream is extremely cytotoxic. So be aware that this is an issue. So what's the best moisturiser to use? Well, a younger patient, most adults, a cream is fine. Most of them contain preservatives, but in a normal situation, that's not a problem. Older patients with good skin use an ointment, which doesn't contain a preservative, and older people or people with fragile skin use a lotion. Again, that's the best way to go. This is a beautiful study done by Professor Carolyn Carville, and she did a randomized cluster-controlled trial of twice-a-day moisturising using your standard aqueous type cream with using a modern lotion. And this was 1,396 skin tears in 424 residents. And what it showed was the residents getting the lotion twice a day reduced the risk of skin tears by 50%. That is very statistically significant. Designed to prevent barrier applications. There's a lot of barrier product out there, and they prevent water and solvents, alkalis, and other noxious agents, again, getting in contact with the skin. Again, in similar way to emollients, they're impervious as barrier between the skin and the environment. Again, you should apply them to the periskin area around a wound. This protects the periskin from exudate and similar things. So there are a number of these ones. They come in sprays, in little sticks. There are a number of ways to use them. There's no evidence that one is better than the others. So, look, choose the one that you think works best for you. Again, polymer films, zinc oxide ones. Again, the zinc oxide ones can be quite useful around the pressure injuries, particularly if they're very exudative. Again, there's good evidence for that. Be aware that you can get allergic reaction to topically applied emollients. Again, this depends on some of the ingredients that you get in them, particularly propylene glycol can cause them, or lanolin can cause them. So be aware that this can be a side effect. The palliative patient is among the highest risk group of all patients for developing complications. Again, this is due to the multiple factors, comorbidities, and patient issues that you're going to have. It's our responsibility to ensure that we aim that our practices minimise pressure injuries, ensure that every effort is made to prevent them by using good surfaces, by using good moisturising on the skin, to look at the diet of the patient, to provide the most comfortable and the best quality of life for these patients in their final weeks and months of life. And it's looking at this total holistic management, the pain management, the skin management, the pressure offloading. When you put all of these things together, they're going to have a significant impact in your patients. So I hope that's helped to clarify the issue, to give you some better understanding of the best way to approach them. Look at how the surfaces you're using are used correctly, because just because you've got the right surface, it doesn't necessarily work unless it's being used correctly. Again, management of palliative care, the important issue from my point of view is patient comfort and symptom reduction. You've got to give them the ability to have those last days and weeks of life as comfortable and as free of odour, or free of pain, or other issues as possible, so they can, in fact, enjoy the last remaining time. And as I said earlier, in relation to analgesia is absolutely important, but you don't want to have them so zonked out that they can't communicate. And I will recall talking to one of my patients who was a relatively young man who developed extensive metastatic cancer and was told he had a very short time to live. And he had significant pain. And I asked him, do you want us to provide analgesia so you have no pain, but the risk is you won't be able to communicate? Or do you want us to maintain you at a comfort level that you can still communicate with your loved ones and with other people? And that, he said, that's what I want. I don't want to be so zonked out that I can't communicate with the people that I love. So I think that's a very important part of the management of palliative care. So thank you.
Thank you. And on behalf of the Hospice New Zealand and the register sites, we'd like to thank Dr. Sussman for sharing his time and knowledge with us this morning. Thank you, everyone, for listening today. We hope that you found this lecture interesting and informative. Have a lovely day.